Well, hello again, and welcome to module this, part 2. Sorry, I don't have my notes in front of me on that. We're going to discuss nutrition care plans and the ADIME. Okay, so, care plans are used by pretty much every healthcare discipline, and as opposed to some stuff I've argued about before, I'm really like, I don't like them that much. I like care plans. I actually think care planning is an extremely good way to solve a problem. It's not something I say very often about these kinds of tools, but I do like care plans quite a bit. When you really boil it down, there's lots of ways to describe care plans, but care plans want to know 4 things. They want to know what problems does the patient have, what are you going to do to fix it, how are you going to know when it's fixed, and how will you prevent it from recurring, and how will you know if it comes back? That's it. Those are the 4 questions you need to answer with a care plan. Thanks, guys. Have a good one. No, I'm kidding. There's more. Sorry. So, the nutrition care plan is your assessment of the patient's condition and your plans to address it. Your goal with this is to be clear and concise. And I will tell you, I struggle with this sometimes. I have bad literary elephantitis with this. It grows and grows. And I'm very detailed sometimes, but probably way more information than people need. What I try to remind myself and other people is you have 90 seconds to tell the doc everything you want her to know about the patient. This is your chance to make your case. This is what's going on. This is why I think we need to do what I want to do. This should be the outcome. Go for it. Remember when you do care planning and notes, or the power of the written word, you always write what you say, the patient says, what you're going to do, and how the patient feels about your plan. And the most important thing to remember is if it's not written down, it didn't happen. God forbid you ever end up in some sort of lawsuit, bad survey situation, and you didn't write something down. It's your word against theirs. So write it down. Always remember that. If it's not written down, it didn't happen. Now, the ADIME, aka the Nutrition Care Plan. This is the Academy's preferred method of dietetic charting. It's not the only one, but it is the Academy's preferred. They did it in conjunction with Aspen. They're very proud of themselves for it. Surveyors, federal and at least in Texas, are taught to look for and read ADIME notes. I can tell you that. So they definitely are aware of them. For this class, ADIME is not required. There are other charting options. I think they're suitable. There's no reason you can't. But I am going to teach from ADIME because it's the Academy's preferred method. So, real quick, the sections of it. It's a fun acronym like all these other ones. A is the assessment, what your patient looked like, said, did, their labs, their diet order, their estimated needs. This is the stuff you've been doing already. Diagnosis, boy, my English is on fleek today. PES statement, PES statement, nutrition diagnosis. I is intervention. This is how are you planning to address the issue that you have just diagnosed. M is monitor. How will you know it's working? And E is evaluation, which is how will you determine success. I feel a lot like this is really just monitor again. We'll go into that later. More on that coming. So the assessment is, like I said, this is what you've been doing so far in the other ones. What's going on with the patient? It includes subjective and objective information. This is your ABCDs section. And this is the foundation of your entire course of care. Everything you do from here on in will be based on the assessment. Now, it doesn't have to be, I did send an example out of what I would do, and it is what I would do. It doesn't have to be like that though. It can be in mini SOAP format. It can be bullet points. It can be a narrative. I'll be honest, I find bullet points easier to read on a personal basis. However, I find narrative notes easier to write. So my notes tend to be narrative. Either way, be sure to include the patient's observations, thoughts, and whether they understand and agree to your intervention. This isn't agreeing as far as like they're excited about it and they're like this is what we're going to do, because if they could do that, they wouldn't need you. This is just have you explained the intervention, what needs to happen, and did they agree with you on that? So very quickly, I don't even know if they talk about SOAP format anymore. I don't think there's anything wrong with SOAP myself. So SOAP is subjective. So these are, remember, symptoms. How does the patient feel? What do they look like to you? What do they say about themselves? Objective. The O is objective. So we're talking signs, vital stats, the status of the patient, who else was there at the time. The assessment is A. What do you think is going on? And the P is the plan, which is what are you planning to do about what's going on? That's SOAP. It's pretty much answering the same questions. Okay, for the diagnosis, whichever format you use, whether you use ADIME, whether you use SOAP, use the PES format. It's the one thing inspectors absolutely know to look for. Later in the next module, I'm going to link some surveying materials, like what they're taught to, it's public information, what they're taught to look for, and the PES is literally one of the things they're taught to look for. So they know that. The standard format is thingy related to yada yada as evidenced by whatevs. The thingy in this case is the problem you come up with, the nutrition-related problem you come up with. Yada yada is related to, is the language they chose. You could also say because, or you can't say that. You need to stick with the language they use, because this is very, very formulaic and specific in how they want it written. But you can think of it as because of. And then as evidenced by, whatever the evidence is. Now it's important to remember that the evidence does not back up yada yada. That's done by somebody else, usually. Especially if it's a medical diagnosis of some sort. That's not you, that's the doctor. Your evidence is backing up your problem that you came up with. Just to point that way for you guys. Your evidence backs up the thingy. Now, because it's so important, listen, because surveyors, JCAHO, whether it's JCAHO, whether it's a state surveyor or a federal surveyor, they know to look for a PES statement. So that's the one thing, again, that is required in this class for Unit 4 and for your nutrition care plan. Include PES statements. So let me just share a couple that, some that I do regularly within geriatrics. So, inability to follow nutrition-related recommendations related to dementia as evidenced by not oriented to time and place and patient behavior. So the comma is just a quick way to say this and this. So, inability to follow nutrition-related recommendations is the problem. The etiology, the reason for this is dementia. And my evidence for her inability to follow nutrition-related recommendations is that she's not oriented to time and place and her behaviors are strange. Now that could also be clues as to the fact that she may be developing dementia. But in this case, remember, you are backing up your problem. So not oriented to time and place and patient behaviors is supporting inability to follow nutrition-related recommendations. That's it. Increased PE. PE is protein and energy. I'm just a lazy typist. Increased protein energy needs related to wound status as evidenced by estimated needs. The problem is they have increased protein energy needs. The reason for that is that they have a wound. You could just say wound status, or positive wound status is what I usually say. And as evidenced by estimated needs, the needs that I came up with for them. You don't have to do that. You could also do as evidenced by the NPIAP, or was it National Pressure Injury Advisory Panel, as evidenced by something else. And it just needs to be a reason that you, again, the evidence needs to back up your problem. They have increased protein energy needs. My evidence that they have increased protein energy needs is my estimated needs or the recommendations of the advisory panel, and my estimated needs would be based on the advisory panel, so either would work. Inadequate oral food and beverage intake related to anorexia, dysgeusia, as evidenced by PO intake not meeting estimated needs. So the problem here is they're not eating enough. Inadequate oral food beverage intake. The reasons why: anorexia, dysgeusia, they're not feeling hungry, the food tastes funny. And how am I backing up my inadequate oral food beverage intake? The intake's not meeting the estimated needs. Again, remember, I don't have to prove what the etiology is. I have to prove the problem. Difficulty chewing related to poor denture fit, as evidenced by patient statements. Decreased PO intake. The problem is difficulty chewing. And it's related to poor denture fit. That's the reason. As evidenced by they told me so, and they have decreased PO intake. And this is another time to point out that, again, while the patient statements do support poor denture fit, that's not what I'm here to do. I'm saying they're having problems chewing, and the reasons they're having problems chewing is because they're telling me so. So it's easy to get turned around in a PES. Another one here, overweight, obesity related to exercise, overweight, obesity related to excess E intake, lack of physical activity, as evidenced by BMI. Now, remember, this is geriatrics we're talking about, so I don't tend to worry about somebody who's overweight unless they are right on the borderline of becoming obese. Obesity, yes. Overweight, maybe, probably not. But the problem here is overweight obesity, because that's how they write it in the diagnoses list. Why are they? It's because they're eating too many calories, lack of physical activity, and is evidenced by BMI. Remember, again, I'm proving obesity. I'm not proving excess E intake. I'm proving the problem. And then the last one here is no PES at this time. There's not a lot of places you can totally get away with this one. Long-term care of geriatrics is one, specifically because that's what we want. We want them to be nice and stable, nothing going on, steady weight, eating pretty regularly, no other issues. That's what we're actually after. That's the goal. I don't get to do that a lot. I get to do that sometimes. There we go. Sorry, I had a little bit of a hiccup there. All right, so let's go to the intervention here. We've talked about the problem quite a bit. Let's talk about the intervention. The intervention is, what are you going to do about the problem that you have just diagnosed? Now, it should be practical, meaningful, and relevant. It should also be possible. So if you have someone who's obese, don't say this person is going to lose 200 pounds. That's not practical. That's not possible. It would be meaningful and relevant, but it's not practical or possible. Remember also that we aren't here to, we're not fitness professionals, we're here to make people healthier, not look like supermodels. So you only need to start getting a benefit from weight loss 5 to 10% of weight off. So a much more practical, meaningful, relevant, possible goal would be something like patient to lose half a pound a week to a goal weight of whatever, 5 to 10% less than where they are now. You could even say goal weight 10% less than normal or than current body weight. That would be fine. It's also important to do something. If you identify a problem, you need to address the problem. Don't just say, this person has this issue, that really sucks. This is also why dietitians, many of them, do not like things like altered nutrition related labs for something like kidney disease. What are we going to do? I mean, we could help to a point as far as make sure you're taking your binders, make sure you're following your renal diet, but that's not a guarantee it's going to help. So some dietitians object to something like that it's something that they can actually impact. They're not, whether that counts as doing something or not, but it may not be impactful. It's also important to discuss your intervention with the patient and report their thoughts in your note. So you want to make sure they understand what's happening. That's always the first question I ask somebody when I start working with someone that has diabetes is, do you understand what's going on? And if they say yes, I will say, explain it to me. Tell me how diabetes works. So we can skip some time if not. And if there are any holes in their understanding, I can correct them as I go. So discuss it with the patient. If they understand the problem, explain the intervention, make sure they understand why the intervention is important, and then report their thoughts. Now, how they respond is not a grade on you. Generally speaking, we're not known for giving really fun advice to people, right? You need to cut back on your alcohol. You need to cut back on your carbohydrates. You need to lose some weight. Whatever. We're not known for having fun advice. It's not that they are. Patient was ecstatic to learn this. No, that's fine. What you want is patient understood, and you can say patient is motivated, or they expressed concern about their ability to do it, or they're unhappy about it, and that's fine. That's fine. We're not expecting people to be overjoyed with the things that they have to do sometimes. That's perfectly fine. And if you can, get buy-in, especially on somebody that's developed a condition and you've stepped in early. They've just found out they have diabetes, going back to that previous example. Now is the time that you can talk to somebody and say, look, I know this sucks and I'm really sorry it happened to you, but you don't have to live a weird life. You're not going to be a shut-in and a recluse and isolated from everybody. With just a few minor changes, you can live a normal life. And that's great. That's great to hear for somebody, and it's your opportunity it's nice if you've ever had a chance to do that, to kind of walk somebody back off the ledge. Come with me. This is what we need to do, and I can help you get there. It's even better when there's family involved, because the more support that person has, the more buy-in you can get from everybody, the better their chances are of doing well with the interventions. Monitoring and evaluation. Monitoring and evaluation is what markers are you going to look for to see if the intervention worked, and when will you declare success or decide it's time to try something else. Both of those are possible outcomes. And this is where I said I feel that this is essentially the same thing. Say I have someone who wants to lose weight, and I say this patient's going to lose half a pound to 1 pound per week. And how am I going to know that they did that? Well, we're going to weigh and compare how many weeks it's been to when the last time they weighed. I can't do one without the other. I consider it the same thing. I usually just put them into one sentence at the end together. You don't have to. I mean, by all means, you don't have to do what I do. I'm just that's if you ever looked at one of my notes, you'd be like, "There's no evaluation statement." It's in the monitoring statement too. Okay, so the last thing real quickly here is stacking PESs. This is a debated issue with dietitians. Some dietitians prefer to choose the most important issue that the patient needs to be addressed for the patient. There we go, and focus on that. Some list multiple PESs, one for each. I call that stacking. There's no official term. Feel free to borrow stacking or come up with your own term if you have one you like better. I don't care. It's just what I made. It's just what I call it. There's no official word from the Academy on this about which way they prefer to go with it. So how do I stack? If you're going to stack, I do think you do open yourself up to a little bit more vulnerability than if you don't. The way I do it is one of three ways, I guess you'd say. If we have three problems and they all interrelate together, I will write a PES for all of them. And I've just done the first part of each one of these. But say I have somebody that's like inability to follow nutrition-related recommendations. That's leading to an inadequate intake related to their inability to adhere to nutrition-related recommendations. And then they have unintentional weight loss, which is related to their inadequate intake because of So that's one way you could stack them. You could also, in theory, actually switch 2 and 1 if you want to, since the Academy prioritizes intake, and say inadequate intake related to inability to follow, and then inability to adhere, do it that way instead. That would work also. That's kind of the good and bad thing both about PESs is that there's more than one way to answer the question, which means you have more than one option. It also means that there are more than one way. There are more ways to get it wrong. So, other than that, I either go by, I guess it's kind of the same thing, by primary, secondary, tertiary. In that one, we saw they had an inability to adhere because of probably dementia. Their secondary one was that they didn't eat enough because I couldn't encourage them to eat enough because they had an inability to understand. And then the third one was that they had unintentional weight loss because they weren't eating enough because they couldn't understand. Another one would be something like Gertie, if you remember Gertie from way back when. I remember she had wounds, she had kidney disease, she had other. So you could say that her most immediate was that she had increased energy needs, energy and protein needs related to a wound. Her secondary would be that she had kidney disease, and you might even put a note on the side there that you're like wound status versus kidney disease, so they know that you're like, yes, I'm aware that they have kidney disease, and I'm suggesting extra protein. I understand it's important, etc., etc. So you could build that way also. If you do that, always keep in mind Owen's triage dictum. Remember, if you're going to find the thing that's the most important, the thing that's most dangerous, address that. And Hickham's dictum, which says, remember, they can have as many problems as they damn well please. If you're finding lots of issues, that's fine. May have a lot of issues. It's not a reflection on you or the facility. It's just how it is. All right, guys, that is I just blanked. Nutrition care planning, or the nutrition care process, and ADIME. I will catch you next time when we're going to do a little bit, I promise it's small, about regulations, rights, and facility types. I will catch you there. You guys have a good one. Bye.